Thanks for the chance to present to you today on early approaches to early sepsis recognition, the search for the Holy Grail. My name is Halden Scott. I'm a pediatric emergency medicine physician in Colorado. So many of my examples will come from the United States emergency medicine practice, but we'll be talking a lot about how to pick the right diagnostic approach for whatever setting you are in. I have no disclosures. By the end of my talk today, I hope that you will be able to describe patient, clinical, and laboratory features that are best for the early recognition of pediatric sepsis, understand the components of a recognition bundle for rapid identification of septic shock, and consider how to customize a pediatric sepsis diagnostic approach for the resources and patients in a specific setting. Before we can talk about diagnosing sepsis, we have to talk about what it is. And that leads us to the conundrum of sepsis definitions. The definition of record remains the one that was described in 2005, really designed for prospective clinical trial enrollment that was based on the SIRS criteria, a set of vital signs associated with inflammation or infection. However, since this definition came out, multiple studies have shown problems, particularly with the SIRS criteria component of it, which is both low sensitivity and low specificity for pediatric sepsis. Adult sepsis definitions were redefined and renamed in 2016 as Sepsis 3.0, with an emphasis on organ dysfunction. And since then, pediatric leaders have described the need to and proposed ways to adapt the pediatric sepsis definition with a focus on organ dysfunction. And that's the definition that we'll use for the purposes of diagnosing sepsis in this talk today. You may ask, what is organ dysfunction and why should I care? And these describe system by system what the organ dysfunctions look like. You'll notice I've included asterisks because the precise cut points for determining that a certain system has achieved organ dysfunction is what is up for debate. So everyone agrees acute kidney injury represents renal organ dysfunction, but what degree of elevation in the creatinine for a specific child's age and gender represents true organ dysfunction is still up for debate. In functional clinical practice, this means that you can use whatever standardized, agreed upon consensus organ dysfunction makes sense in your hospital setting. The second part of my question is, why should you care? These are some articles that build the case for why organ dysfunction matters in pediatric sepsis. Each of these studies focused on a specific organ system, kidney injury, DIC, and vasoactive inotrope score as a representation of shock, and showed that organ dysfunction in even just one system was associated with worse outcomes. And of course, there are specific management implications of, for example, AKI, which might cause you to dose antibiotics differently. But it's more than individual systems. This survival chart shows the number of organ systems that was dysfunctional at the time of ICU admission. So you can see the bottom line with the worst probability of survival were it's patients with more than 4 organ dysfunctions. On the one hand, this is somewhat intuitive. More organ dysfunctions, worse survival. But it's important to note that this is at the time of ICU admission. For me, as someone who works in a pre-ICU setting, this emphasizes the importance of identifying organ dysfunction early, knowing how many systems are dysfunctional in a patient who's critically ill, and getting them into ICU care as soon as possible. So this is why the number of systems matters. While some of these organ dysfunctions can be identified clinically, some can only be identified if laboratory tests are measured. So when there is a suspicion for sepsis, a suspicion that a child with infection is looking worse than the average mild upper respiratory infection, it is important to take that next step and perform a lab draw to obtain these labs where they're available. And there's implications of this infection plus organ dysfunction definition. It means that diagnosis does not require microbiologic confirmation, and treatment must be started as soon as there's suspicion for infection in the setting of organ dysfunction. So the learning point from this definition conversation is that sepsis is organ dysfunction in the setting of suspected infection, and laboratory testing is required to check for all organ dysfunctions. The clinical implication in designing systems to support sepsis care is that a full set of organ dysfunction labs must be checked when suspicious for infection in the setting of an ill-appearing patient. What are clinical features that may aid in early sepsis recognition? I present here a meta-analysis that was performed by the Pediatric Sepsis Definition Task Force. It pooled studies of children with infection to identify clinical predictors associated with the outcomes of sepsis, multisystem organ failure, and death. There are some caveats. Although studies came from all over the world, the number of children included in the pooled meta-analysis largely came from high and upper middle income countries. Largely, the included patients were also ICU patients. So this gives us more of a window in how to prognosticate sepsis once a patient is in the ICU, rather than that earlier question of how do we identify the potentially sick child from all the other children with fever. Looking at the outcome of sepsis, severe sepsis, or septic shock, the clinical variable that was associated with this was decreased level of consciousness or change in mental status. I'm highlighting on this slide and the next coming slides in yellow the pooled estimate of risk of patients who had this finding. So you can see that an altered mental status was highly associated with this outcome. PRISM score, a measure of organ dysfunction, was as well. Looking next at variables associated with the outcome of mortality, I've again highlighted in yellow that risk estimate. And they fell into groups of demographic variables, including malnutrition, chronic conditions, and oncologic conditions, and clinical variables. These were all variables associated with shock. Mechanical ventilation, you'll note with an estimated risk of 11, is even more highly associated with death than any of the variables we've talked about so far. Decreased level of consciousness and Glasgow Coma score came up again. Looking at our laboratory variables, all of the variables listed here were associated with the outcome, but you'll note that specific ones, creatinine with an estimated risk of 13, platelets with an inverse association, so a negative risk of 87, lower platelets, higher mortality risk, and ALT or liver dysfunction was also associated. The findings from that pooled meta-analysis are similar to those that were seen in this analysis of organ dysfunctions and their association with death. And you'll see that respiratory organ dysfunction, neurologic, and hematologic organ dysfunction had the highest odds ratios for being associated with death. What can we take from these studies? The clinical signs most associated with sepsis and death in children with infection were altered mental status, hypotension or shock, and the need for ventilatory support. Ideally, we would like to identify children before they reach this state of shock and altered mental status, but it is really important that our systems are built so that maximal resources can be activated when these clinical findings are present. We'd like to find children sooner, but when these are present, that all the systems in our hospitals and emergency departments are geared to deliver everything the patients need, and that all of our clinicians understand the real significance of these particular findings. This brings us to the recognition bundle. The idea of a care bundle in medicine has been described as a set of 3 to 5 evidence-informed practices that, when performed collectively and reliably, can improve the quality of care. Pediatric sepsis bundles were first suggested in the American College of Critical Care Medicine Clinical Practice Parameters published in 2017. And you'll note on the right the recognition bundle, resuscitation, stabilization, and performance bundles. Today, we are talking about the recognition bundle, which includes these 3 steps. Screen the patient for septic shock, clinically assess the patient at bedside within 15 minutes for any patient who screens positive, and initiate the resuscitation bundle within 15 minutes. It's important to note that this specific bundle hasn't been prospectively tested as these 3 specific steps are exactly the ones that are associated with improved outcomes, but quality improvement studies incorporating this idea, this process of clinical recognition that includes screening, clinicians to bedside, also often called a huddle, and then resuscitative care, in quality improvement studies has been associated with improved outcomes. So what is the ideal sepsis diagnostic tool? Well, it would predict all sepsis states, severe sepsis, shock, mortality, work in all settings. It would be better than humans, but when it was running, it wouldn't impair our own judgment. Unlike a computer, it would have no downtime. It would be easy to implement and be 100% sensitive and specific. As you've probably guessed from the title of this talk, this holy grail still has not been found. So we need to consider trade-offs and prioritize which aspect of this is most important in the setting in which we practice. I'm going to give you some examples of tools that have actually been implemented into clinical care. There are a number of models and sepsis diagnostic tools that have been described, but not as many have had their actual performance described. What happened after this went into practice in an actual hospital? So a number of these examples are going to come from US emergency departments, where there has been a plethora of publications on the implementation of tools, but there are other tools that exist throughout the world. We just haven't seen published studies of their effectiveness yet. So one category of tools is definitions-based. Dr. Eisenberg and colleagues in Boston and Dr. Sapansky and colleagues in Virginia both implemented what is essentially the Goldstein consensus definitions based on SIRS into their electronic health record, and tested how it would not predict sepsis, but would identify patients once they had it and ensured that clinicians were recognizing sepsis was present. There are also more predictive tools. These were really developed by consensus opinion by the American Academy of Pediatrics Septic Shock Collaborative. On the left, you can see what this consensus predictive tool looked like as a checklist on paper, and on the right, how it looked when it was implemented into the electronic medical record. This one is from the Children's Hospital of Philadelphia. So in considering your options for diagnostic tools, you have to think about which aspect of the tool is most important to you. So let's think about the workflow in an emergency department. A patient arrives and we make a decision to draw labs. It's invasive, but it's sort of lower risk to the patient. So I would prioritize sensitivity here. It's okay if we stick a few children we don't need to in order to find the ones who have a potentially fatal condition. When we give antibiotics, there's more of a downside to that child and the world of giving too many antibiotics. So we have to balance sensitivity with positive predictive value if we're using it at that point in the workflow. And then in disposition, we need sensitivity to make sure we don't send someone home who might have a fatal condition, but I don't want to overuse my ICU beds, so I need to maximize specificity at that time point. In an inpatient setting, we have a similar balance. When we're making the decision to call the attending, or as you would call it, I think, the consultant, sensitivity is probably the most important. What's the downside? Waking up someone who doesn't want to be awakened. But the upside is potentially saving a life. So sensitivity would be prioritized. Although it's true that the attending or consultant at home might say your number needed to call or to treat is too high at this point. A huddle process is similar. And then when we're giving antibiotics, again, we need to balance the positive predictive value. So really, the tool that you choose should have test characteristics that make sense for the point in your workflow where you're implementing it. When we compare, so you're here probably wanting to know which tools work best in these forums. And one difficulty in comparing tools and looking at the published literature is that everyone used different outcomes. In some cases, they said treatment for sepsis was the outcome of interest. Some people might consider a patient who received fluid and antibiotics and never developed shock or organ dysfunction to be a good catch and a positive, whereas some might say that wasn't really sepsis at all. Your tool was a false positive in that case. And some use administrative codes, chart reviewed organ dysfunction or mortality. So here's an example of some of the tools that have been published and their test characteristics in live actual experience. These are all from US emergency departments, and you can see that the sensitivities and positive predictive values ranged. In general, more sensitive tools had lower positive predictive value, although that was not always true. Some really just performed a little better than others. I want to highlight some of these were built into electronic health records, and some of them were paper-based. I also want to describe what we did in Colorado, where before we implemented any tool, I wanted to know how our actual clinicians were doing. How did we do in our native state before a tool was implemented? And we found in a tertiary emergency department in the US, a consultant or attending is present seeing patients 24 hours a day. And so the sensitivity in our tertiary ED was actually quite good at 94%. And I sort of set this as anything we're going to implement has to perform as well as our doctors are already doing. However, our community ED, which saw less acute pediatric patients, had a much worse sensitivity. So you can look at that and say that community ED could benefit from one of these other tools that has been implemented. That would improve our sensitivity. So where does this leave us? We have to recognize some of the limitations of existing diagnostic tools, read about new ones carefully. Are they designed for prediction or confirmation of sepsis? And are the predictors that they used available to you? For example, if a tool uses lactate or procalcitonin and that's not a value you can get in your emergency department or inpatient setting, that's not helpful. Conversely, there's a predictive score, the Liverpool Q-SOFA, that's quite useful, but it didn't include blood pressure, which is a really strong predictor of outcome in sepsis. And that's something we measure on all of our patients. So we didn't want to pick a tool that didn't use something we had readily available that was quite useful. And then consider the implementation and workflow. I've left you with a variety of options, and you may say, why is this important? Do we know that using these diagnostic tools work? And I would say yes. What's really important is standardizing and expediting systems within your own healthcare setting. These are studies from 4 different children's hospitals, all of whom had a slightly different recognition and diagnostic process. And yet, each of them in these quality improvement studies showed improved outcomes with the use of their standardized process. So doing things the same way in a way that everyone in the institution understands is one of the most important elements of effective sepsis diagnosis. So this brings us back to the recognition bundle. Having a screening process, these lightning bolts represent kind of systems you can build within your healthcare setting, that when someone thinks they have sepsis, there's some process to call a huddle or bring clinicians to the bedside. And if those clinicians agree that this is sepsis, that the resuscitation bundle or treatment can start right away. So the learning point is that multiple sepsis screening tools exist. None has been established as being definitively superior. So it's important to consider your local context priorities and standardize your systems. Thank you.